good afternoon, good morning. We're all different time zones today. So thank you very much. The topic is understanding fixation. Everything we do in histology is dependent upon this one word called fixation. And therefore, understanding it is of the extreme most importance. And so while it seems like a simple little word, I think we're going to find today how complex it can be. So fixation is the foundation of histology, and I refer to it as being the base of the tissue processing pyramid. What our end product, it's the tip of the pyramid. It's something visual. It's what we see as a dye. It could be the chromogens. And how something looks is totally dependent on how it was processed. And that very first step in processing is fixation. So everything is totally dependent upon fixation. What we want to know is, how does fixation really work, all right? If you go to the definitions, we say that it's to prevent autolysis and putrefaction, and that all really depends upon changing the three-dimensional shape of our molecules. And another fancy way of saying changing the three-dimensional shape is the term denaturation. Now, the way fixatives work, the molecules, and we'll be talking about several of them this session, is that the molecules add on, and they actually cause, the fixative adds on, and actually causes the molecule to fold and twist on itself. And instead of actually showing you a molecule to do it, I got here on the screen as a balloon, okay? Something simple to visualize. And the balloon on the left is how it's blown up. So think of the balloon on the left, as the natural shape of a molecule, a protein, carbohydrate, all right? After a fixative molecule has attached to it, cause it to fold and twist on itself, that balloon now has totally changed its three-dimensional shape, and now it looks like the balloon on the right, the dog balloon, okay? So that is what fixative does. It totally changes the three-dimensional shape of the molecule. So the question is, why do we want a new shape? Why is this so important? Denaturation is very, very important because I already told you we want to stop autolysis and the rotting mechanism that can naturally happen. And to prevent that from happening, those autolysis and putrefaction is dependent upon enzymes. They could be the normal enzymes that live in our body, or they could be the enzymes of bacteria, okay? So those enzymes are causing autolysis and the rotting mechanism. Enzymes are very, very specific to molecular shape, all right? A specific enzyme will only work on a very specific shape of a molecule. So when a fixative has gone and changed the three-dimensional shape of a molecule, the enzyme can't work. So as you're seeing there in the graphics, the enzymes, the bacterial enzymes, the enzymes of our body that normally would work on a natural-shaped protein, the natural-shaped balloon, that same enzyme cannot work on the dog balloon, or the dog balloon is the fixed specimen, okay? So that is why we want to change the three-dimensional shape, to prevent autolysis, putrefaction, okay? So that is what's so very, very important. Now, no matter which fixative we're going to end up using, there's variables that are common for every fixative we're going to use. Okay, there are variables for fixation, and the two most important, these are the two major ones. Definitely time, okay, and we're going to talk about time when we're talking about actual specific fixatives and their formulations, okay? But another one that we do have control over, sometimes, depending upon administrative situations, is the volume. Now, here you can see 6 different specimen containers, and the little brown speckle thing in there represents the tissue. All right? Textbooks tell us we want there to be a 20 times more volume of fixative than the specimen. All right? Now, I know and you know there are times our specimen is so huge that a 20-to-1 volume is impossible. But whenever possible, we've got to make sure we have that excess volume. Because remember, the tissue is filled with serum proteins and lipids. And what's happening with the specimen as soon as it's put in? The fixative is going in, it's pushing out the liquids that are in the tissue. So don't think that while it's in that fixative that you've got that much fixation going on, because as it's sitting in there, the longer it's sitting in there, the longer it's sitting in a fixative that I refer to as being used. All right, it's being diluted with the fluid, and we're going to see examples of this, what it can, the actual artifacts that can appear, even though you may have it sitting in a specimen container for 30 or more for overnight. You can see it's not getting its optimal fixation. But let's go to the next slide and see what the world of perfection of fixation can provide us. Give it the perfect time, give it that perfect volume, perfect grossing. We know how important that is, all right? And you can see, obtain a specimen that you've got right here. This is a section of colon. You can see the epithelial cells, where there actually are 2 types of nuclei that you should be able to see. You should see the nuclei that is known as open, all right, where you can see the nuclear membranes, the chromatin inside. And then we also have nuclei that are compact, that are very dark staining, all right? Both of those are normal nuclei that you can see there. If you know your histology, you can see in that gap area, this being intestine, you can see the microvilli. The red blood cells are nice and sharp. The cytoplasm of the cells have the alternative color. This is perfect fixation, all right? That came about because we fixed long enough, put it in a large enough size container, and it was gross so that the fixative could get in there. The next slide is showing you what happens when we have improper fixation. A whole range of weird aberrant staining can show up here, all right? The circle on the left, you're seeing nuclei with no chromatin pattern. You're seeing them washed out, all right? The slide on the right, all right, is showing you the famous soap suds nuclei. When you take a look at inside any of those nuclei, they actually look like there's bubbles inside. And this has been referred to as soap suds nuclei. Sometimes people have referred to it as nuclear meltdown, all right? All of these was because we did not provide enough proper fixation so that the base of the pyramid that I showed you earlier is weak, and everything that comes on top of it, the processing, the staining, is going to show up abnormal. So what causes this? All right, yeah, we talk about this aberrant staining. Generally, you can almost take it always right back down to the lack of fixation time. All right, I use what's known as the unwritten rule, okay, that people have followed this unwritten rule that says your fixation time should be 1 hour for every millimeter thickness. So they're thinking with the tiny biopsies that are no more than 1 or 2 millimeters thick, that all they need is 1 or 2 hours of fixation time. But that unwritten rule is really only applying to getting the fixative into the cells, to where the molecules are. Once a fixative gets inside, we must give it time to start chemically reacting. All right, so let's start taking a look at a situation that I showed you about proper fixation. On slide 9 here is a situation that occurred, and the text sent me the slide on the left, and the problem was what's inside that circle that the pathologist was constantly complaining about, this washed out. You could see no good nuclear detail of what was going on. Now the tech thought that there was adequate fixation time because the specimen was taken in doctor's offices. It stayed in the small specimen container overnight. It was brought in by the courier. So here was a very tiny specimen in a very small amount of fixative. It got to stay in the specimen in the pre-fill container overnight. So with her busy schedule and needing to get the slides out to the pathologist as soon as possible, she logically thought, I do not need any fixation on the processor. It sat in the specimen container for easily 8 to 10 hours. All right? Her processing schedule was decent. She actually was using an fixative much better than neutral-buffered formalin. She was using a buffered zinc formalin, which you'll learn shortly how that improves fixation. And her processing schedule was gentle. But what she did, she went immediately into alcohols to start the dehydration. So she started in 70, went into 80, 95. So there was no heat on. So her processing schedule was really decent, all right? But there was no fixative on the processor to save time. Now, realizing what that specimen, while it may have been sitting in a fixative overnight, it was sitting in that old fixative. So here you've got colon biopsies. They're filled with mucus. May have been sitting in fixative overnight, but it wasn't getting optimal fixation in terms of the quality of the fixative. I asked her just to put fixative on the tissue processor, and she immediately said she had no extra time, could not afford to put time on. So by taking a look at the multiple alcohols she had, we came to the conclusion that we could steal one of the alcohols and just give the fixative, give the processor one 30-minute station. And that's what you're seeing on the right. She immediately, by having that freshness of fixative, now true, she still was using the buffered zinc formalin, she lost all of that washed out. I mean, she actually got cell membranes popped. Now, for me, the nuclear detail was still too dense, but the pathologist was totally satisfied at this point, okay? And we know the rule. The happy pathologist always rules, all right? But I want you to see the difference, what just 30 minutes of fixation did, and to let you know, just because it sat in the specimen container for hours and hours, you're not getting maximum fixation there. Because that fixative, because she really didn't have the 20-to-1 volume optimal, and it was sitting in used fixative all that time. So think carefully on how the freshness of your fixative applies here. Okay, let's start talking about the chemical reactions and take a look at our famous fixative that's pretty much used 90% of the time, okay, and that is good old sweet formalin, okay? It's used so much it's given its own acronym, all right, formalin fixed, paraffin embedded, all right? It gets its history, and if you understand why we're using it, you may understand why it may not be the most optimal in terms of where it got its start from, okay? It really started back in 1893, all right? Physician by the name of Ferdinand Plum, okay, in Frankfurt, Germany, was doing a project to actually find disinfectants. And while he was using it, he recognized how formalin was able to fix tissue. And he actually realized how well it fixed tissue by the observation on how it worked on his own fingers. There were no surgical gloves in those days. And he realized that his fingers, while he was working with formaldehyde, acquired a really thickness to it, the hard epidermis. All right? And then he'd also thrown a mouse that had had anthrax into formalin, and he realized how that firmed up. So in the solution he was working with to find this disinfectant had been diluted 10 times. There was our 10% formalin, okay? He did some histology. He realized it preserved the red blood cells on the mouse. The natural colors of the tissues were so much better than alcohol, which was being used at that time as a fixative. And so that's where we got 10% formalin, okay, because someone was looking for a disinfectant. Today, we know that it's a cancer-causing element. We know that we shouldn't be exposed to it in levels really more than 0.5. Action levels are 0.75, but OSHA now has given it its own action. It is a definite, product that's used throughout the United States and planet Earth in a lot of different industries. And in fact, it actually brings in $10 trillion of money a year in all of the products that it's being used. So in histology, if we ever stopped using it, no one would really care, because the windshield industry, the brake industry, everybody's going to continue to use it. So, but let's take a look at it. Let's find out what is it really doing to our tissues. Because I told you we need time. Once that tissue gets in, we've got to give it time to chemically react. So what is the chemical reactions of 10% neutral buffered formalin? We buffer formalin because if we just made 10% formalin, there's two reasons why we generally do not use that. One, 10% formalin all by itself has an acid pH, which will allow formalin pigment to form when tissue comes into action with hemoglobin. The other reason why we want it at a pH of 7 rather than unbuffered is because at pH 7, the formaldehyde will attach much more easily to the tissue than if it was at pH 4, which is unbuffered. So what does happen? Formalin reaction has really two steps. The first step is what we call the addition step. The formaldehyde molecule finds hydrogen, which is all over the place on our molecules, and attaches to it. We have this addition product, okay, which is the HCHOH, the methyl group. Now, the tissue is attached, but that's step one. That doesn't cause the firming up. What causes the firming up of the tissue, okay, is the next step. So we've got the addition molecule there. It now reacts with another segment of the tissue where there's another free hydrogen, and those two come together and forms the famous methylene bridge. That is the cross-linking. That is the step that actually does the firming up of the tissue. So when we do neutral buffered formalin, we've got to give it the proper time to penetrate. You may say that's 1 millimeter, but then we've got to give it just as much time, if not longer, to do that chemical reaction step of adding on and cross-linking. Now, the early textbooks, if you go to the textbooks, you'll have some people there telling you you've got to let it fix for a week. Unheard of today. 48 hours. When I started the field, it was not uncommon to let things sit overnight, which is not the case. Today, if you're doing the Herceptin test, check the package insert. They are requiring for neutral buffered formalin 18 to 24 hours. The breast tissue, if you are going to use that test and use it as part of the diagnostic tool, those breast biopsies and breast tissues are supposed to be fixed for 18 to 24 hours. The CAP guidelines for HER2/neu are saying 6 to 48 hours, all right? But depending upon what company's Herceptin test you're using, the 18 to 24 hours was the DACO. Now that can vary with the manufacturer. But if you're following the CAP guidelines, there are times those breast biopsies are coming in and they may not even be given 6 hours. The reason why these companies and organizations are requiring these times is because they know you've got to give it proper time for the penetration and the chemical reaction. Otherwise, the base of the pyramid is going to be weak and what you see is going to be improper. Other organizations also are realizing it. NordIQC, this is a voluntarily organization to help promote immuno actually has this on their website, all right? They want it to be at least 24 hours for small specimens and 48 for larger. And then they talk about what would happen in terms of your immuno results if the results are too short, you won't have uniformity, or if it's too long. In immunohistochemistry, the cross-linking step, all right, is what's responsible for antigen retrieval to have to be done. So as you can see, everyone is saying you've got to give time to the specimens. And let's admit it, time is the one thing you don't have anymore. Get the specimen in, get it out, all right? Because there's somebody out there competing with you that they can give the doctor the results fast, okay? So are there any tricks with formalin? And one of them is using alcoholic formalin, all right? Years and years ago, it was the most popular solution. Not only solution in terms of it being a liquid, but the answer for fatty specimens. And those things coming in late in the afternoon, all right? It actually penetrates the tissue 3 times faster than the water-based aqueous NutriBuffered formalin, all right? You'd want to use a formulation, though. If you're using alcoholic formalin, you've got to use a formulation that's buffered. Because if you just make up 10% formalin and 75% alcohol, that's going to be acidic and you will get formalin pigment. And there's formulations out available for you. But if you think you can make up your own, be prepared. You may be seeing formalin pigment. People like using it on the tissue processor. They may just use it in station 2. You have 2 stations of NutriBuffered formalin. They put alcoholic formalin in station number 2. Regretfully, for HER2, you cannot use it unless you do a validation, okay? The reason why it's not allowed, because in the package insert for HER2, they say alcoholic formalin's not allowed. But the package inserts all do say if you're not going to be following the using fixation of NutriBuffered formalin, that's okay as long as you do validation, and that term validation is very familiar for all of you in immunohistochemistry. What about NutriBuffered formalin and immunoreactivity? The cross-linking that will happen, that has to happen as part of step 2, is great for H&Es, your special stains, to give you the morphology. Let the cross-linking occur, you're going to get that beautiful, perfect look. What it does for immunohistochemistry, the cross-linking will mask the epitopes. That's the part of the molecule that the antibody is attaching to, and it just means that you're going to have to perform that extra step of antigen retrieval. Okay, so let's see some pictures of the impact of NutriBuffered formalin on immuno. We've seen what it can do as a perfect job with H&E earlier. Take a look here. Here is 2 sections of kidney, all right? One was fixed in NutriBuffered formalin for 7 hours, and with 7 hours, the cross-linking has occurred, and we had to use antigen retrieval to demonstrate the cytokeratin, all right? The bottom slide, the cytokeratin is visible. It's very weak, but the reason why is because this slide, and I know this is not normal, but in terms of those of you with vet research, this was fixed for 30 days, a month. Such an excessive amount of cross-linking has occurred that the standard amount of antigen retrievals was unable to demonstrate the cytokeratin. And here's showing you what's going to happen with another specimen. This specimen is a routine tonsil, okay, that came from a clinical lab, all right. It's demonstrating EGFR, epithelial growth factor receptor. And here's showing if you happen to have skipped antigen retrieval with NBF, you get negative staining. It's got to be done. So the question is, NutriBuffered formalin is really great, all right, but it's causing a problem with immuno, all right? And so the question is, are there alternatives to NBF to make things a little bit easier for us as we advance into new fields? And what came about in the early 1990s was zinc formalin, okay? Really in the 1980s, it really got familiar, Dr. Peter Banks at Mayo Clinic, he published a paper. It was a laboratory investigation, and he observed that if you use zinc sulfate in your 10% formalin, that you got a great improvement in nuclear morphology using that zinc salt. And here's a difference. Both specimens have been tested here were fixed in for 7 hours, one in neutral buffered formalin and the second one in buffered zinc formalin. Now, while on the left, with NVF, you can say, well, I can still see, you know, nuclear membranes and chromatin and such. But on the right, without a doubt, you could see what Dr. Banks thought was fantastic. The nuclear morphology was just outstanding, okay? Now, time-wise for zinc formalin, you're really getting double fixation here. I'm going to show you this with the chemistry shortly. When the formalin is going in and adding on, you're also getting the zinc ion to add on. And the zinc is a metal, so it's a metal enhancement that's going on to help give the improved morphology as well as color. So let's take a look at this chemistry of zinc formalin. The mechanism of action, step one, is starting out, we still have formaldehyde in there, so you're still going to have that addition step going on. But at the very same time, the zinc now has the capability of adding on. So we've got competition for the tissue sites. At the end of the addition step, we've got zinc holding on to the tissue molecule as well as the addition molecule of formaldehyde. So that means when step two comes about, which is the cross-linking, now it's very possible where before formaldehyde is looking for all those free hydrogen sites on the tissue molecule, they're not going to see them because the zinc is out competing it. The zinc is there, and therefore you do not get the formation of methylene bridges, and if you do, they are a much smaller number. So let's see what that does to our immunohistochemistry, because before, the methylene bridges caused us to have to do antigen retrieval. So here's two slides, all right? Both have been fixed for 7 hours. The top has been in buffered zinc formalin. The bottom was fixed in neutral buffered formalin. Yes, we're both seeing the cytokeratin. They both were diluted to the same amount, but take a look. The buffered zinc formalin did not have to go through the step of antigen retrieval. We still had to do it with the neutral buffered formalin. It's only because with the buffered zinc formalin, the methylene bridges that's hiding our epitopes are minimally there, and the antibody was able to find the site. So that was great. Now if we take a look at the next slide, which is actually showing the 30 days. If you remember previously, 30 days of NVF, we could hardly see anything, and that's what you're seeing there, all right? Even with antigen retrieval on the bottom, the NVF 30 days, it's minimally there. But the buffered zinc formalin, even after 30 days, we still don't need to do antigen retrieval. So zinc formalin has had an excellent influence, all right, on immunohistochemistry in terms of making your life much easier without having to do antigen retrieval. But we're still having the world of formalin in the lab. You still have the human carcinogen. So what about the next thing that happened to us in histology, and that was the formalin-free fixatives. They came on the scene purely to get that carcinogen out. But when the formalin-free fixatives were being formulated, the one rule the researchers and manufacturers knew, the tissue had to look like it was formalin fixed. Pathologists, the pathologies are identified histology-wise by a certain look, and it's formaldehyde fixation. So the most popular, and probably today the only active ingredient that's being used in formalin-free fixative is a molecule called glyoxal. And you can see there on the right how totally similar glyoxal is to formaldehyde. The active ingredient that is attaching to the tissue is the aldehyde. That's the carbon with those double bonded to the oxygen. Glyoxal is providing aldehyde fixation, just like formaldehyde is. Okay, so let's kind of take a look to see how this glyoxal really looks. All right, these two photographs here are glyoxal fixation. Okay, they are providing the optimal look. All right, totally similar to formalin, and it's because it's attaching the same way. It's formaldehyde. It's aldehyde fixation. Now, ways that it's different than formalin, okay, is fixation time. Okay, generally it's faster than formalin, and the reason why it's faster than formalin is that you saw in that last slide that glyoxal molecule was twice as big as formaldehyde. So the glyoxal formulations that are out there that are providing the optimal results are not just glyoxal in water with a buffer. That type of formulation, generally researchers found, fixed too slow. So they were forced to put other additives and solvents in, and one of the things they put in, several of the manufacturers, was a very small amount of alcohol. And that was there to help the penetration. Now, the amount of alcohol that's been added is just enough to get it through that cell membrane, break through it. And it's not an alcoholic fixative like alcoholic formalin is, but it's just enough. And that, therefore, speeded up the glyoxal to get in. Because of its unique shape of being a dialdehyde and its size, glyoxal generally does not cross-link in the time period that would be used in anatomical pathology. Much, much longer times that are just not practical for histology use. So you're not going to get cross-linking. And on top of it, something that's totally different is that glyoxal with the general formulations that are out there, all right, will lyse the red blood cells. So what does that mean? In the top slide, what that picture is a picture of liver, and dead center in that circle is the central vein. Central vein is usually filled with red blood cells and white blood cells. You're not seeing the red blood cells there. Okay, what you're seeing is the dark spots are the white blood cells. The cell is still there. You see them as ghosts. For a lot of people, especially cytologists and all that, this just makes diagnosing much easier, especially with really bloody specimens, because you can see the diagnostic cells. Another thing that glyoxal does a little bit differently is that it reacts with the amino acid arginine. All right, and I'm going to tell you about that a little bit shortly when we actually talk about immunohistochemistry and glyoxal. Okay, but one of the places we see arginine on a very regular basis that you don't realize is the white blood cells, eosinophils. The eosinophilic granules are filled with arginine, which means your eosinophilic granules will not pop with the pink. You still will be able to recognize the eosinophils because they have a unique bilobe nuclei, and you can still see the granules. It's just that they're not going to pop with the eosin. So let's take a look at glyoxal and what it does with immunoreactivity. We know with the H&Es it's going to have that superb morphology. Now, here it is, two slides here. Both of these are cytokeratin. Both of them cytokeratin high molecular weight and cytokeratin 20. Okay, both of these have been fixed with glyoxal. All right, the fixative is Prefer. All right, that formulation. Both of these antibodies generally require antigen retrieval using heat-induced. Both of these antigen retrieval steps were totally omitted, and we got perfect immuno results and perfect morphology. And this is what we would expect since we don't have the cross-linking. Okay, now I told you that glyoxal reacts with arginine. One of the places arginine is found on a constant level is in the DNA of our molecule, in the nuclei of our cells. The DNA molecule is wrapped around these proteins called histones. Histones are filled with arginine. So therefore, in immunohistochemistry, if you are wanting to demonstrate a nuclear antigen, all right, because you'll be looking at the histones there. Glaxo will be requiring formalin, will be requiring antigen retrieval, all right? So here's a section of a lung tumor, and we're pretty sure it's got TTF, that's thyroid transcription factor in it, okay? And when we stained with a tissue was fixed and prefer, and we tried to demonstrate TTF, we got negative staining when we omitted the antigen retrieval. However, when we did apply antigen retrieval, beautiful results as you see on the bottom. So Glaxofixation does reduce work in terms of immunohistochemistry, but be prepared. There may be times with certain nuclears that you still will have to do the antigen retrieval. Other fixatives, trying to understand the rules, the different formulations. There's the mercury fixatives. Really, I'm hearing that a lot of this is being replaced using zinc formalin. These mercury fixatives came on the scene to help give superb nuclear detail that you want to see when you're doing bone marrow specimens. But now that we have zinc formalin, as well as the Glaxo fixatives that can give that excellent nuclear detail, they're being replaced. Another reason why they're being replaced is majority of the time, besides the toxicity of the mercury, is because of waste disposal. These things have to be hauled away. But the B5, the Zenkers, the Helis, the mechanisms on how these guys are really working is really poorly understood. You know that the B5s and Zenkers and Helis are a combination. Yes, you got the mercury salt, some have alcohol, some of them have formalin. So it'd be kind of like taking the zinc formalin and everybody's competing for the sites. But the mercury in there is a metal enhancement, and that's the item that's actually causing all of the superb nuclear detail because of the metal enhancement. Special fixative, and I don't have a slide on this, is for those of you who are doing microwave processing. There are special fixatives out that allow you to do fixation on the microwave processor. Those guys, majority of them are actually using Glaxo or alcohol. They're not using formalin, because that's the one thing you don't want to be ever microwaving is formalin, because we know what the vapors of that molecule are like at room temperature. You can just imagine how it would literally knock you out if you had heated that. So in summary, while your formulations definitely work better than others, especially those that weren't designed to be an antiseptic like formalin, no matter which formulation you're going to use, remember that the base of this pyramid, which is fixation, has to have adequate time, has to have adequate volume. Questions?
Thank you, Ada. This is a very informative presentation. I'm sure a lot of our attendees are just very impressed with it today. I would just like to share one of our featured products today, and this is also a fixative known as Tissue Tech Clear Fix. It can be used as a primary or sole fixative, or it can be used as a secondary fixative after formalin. It can also be put on a traditional tissue processor, and what's unique about it is that it stays in solution. It does not precipitate out, causing the salts that the formalin does when it's introduced into alcohol on your tissue processor. You can find more information on ClearFix on our website at www.sakura-americas.com. I do have some questions for you, Ada. The first question is the 7 hours related to total processing time or just time in fixative prior to being placed on the processor?
It would be total processing time.
Total processing time. Thank you.
However, I would say this. If the specimen is being grossed, and we're not dealing with biopsies here, just imagine you get a colon resection in and it's now being grossed and it's raw. You can't count the time it was in the specimen container because that's not the specimen that's being processed.
Okay. Thank you. The next question states, thank you for a great presentation, Ada. My question is about slide 13. It mentioned Nordic IQC. Who is
Correct.
that, and why did you mention them?
I'm sorry, I started to talk. Say that again.
It's okay. They're just asking who Nordic QC is and why you mentioned them.
I mentioned them because they were supporting required amount of time for NBF, and they were using times, showing you the longer times that we don't use in clinical histology anymore, of 24, 48 hours. That was just supportive documentation that NBF needs time, and it's really much more time that's longer than we're really using in histology these days. They are a voluntary organization of labs in the Nordic countries, and you can actually go to the website, and they actually list and give you recommendations of procedures for various antigen and antibodies. It's kind of like our HistoQuip program here in use ASCP and NSH, where you can do external assessment. It's kind of the equivalent in Europe for immunohistochemistry.
Thank you. The next question is there a formula for infiltration on a fast cycle with heat and vacuum for time? I believe
Heat, vacuum, and time. A lot depends upon the size of the specimen and your whole processing schedule. So there's not anything we can give up front. I mean, are we talking about biopsies? Are we talking about surgicals? Are we talking about hippopotamus? And I'm not joking on that. It depends upon the specimen, your processor. So there's not one thing across the board.
This one particular attendee is referring to small colon biopsies.
I'm going to have to use the Socrates method of teaching by asking questions. First question is, what tissue processor do you have?
VIP.
I'm going to ask the VIP. We're talking about biopsies. These are colon biopsies. I would start across the board, and I don't like using heat, to tell you the truth.
Maybe this is a question, a conversation we can...
Fixation or processing schedule?
I'm not sure, but maybe this is a question that can't be answered in a forum and needs to be taken offline.
Yeah, that needs to be taken offline where I can ask questions going back and forth. They have my email on the front of the handout. Do they? They may not.
Yes, they do. And,
okay.
She
send me an email on that so we can just work it out optimally for your lab.
Perfect. Thank you. The next question is, are there any drawbacks if antigen retrieval is performed on a glyoxal-fixed specimen when it is not needed?
It will chew up the specimen. Think of antigen retrieval as like you're chewing up the specimen to break the methylene bridges. If the methylene bridges aren't there, the enzymes or the heat will destroy it. You'll lose morphology.
If there's no more questions at this time, I would like to end the webinar here today. Thank you, Ada, for your time. We really appreciate it.
Thank you, everybody.